The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. Kathy Robinson here from the National Association of State EMS Officials. We're very pleased that you were able to join us today for linking ePCRs and registry data. I know a lot of folks are just logging on at the moment. We're going to get started in just a moment, in just a few seconds, while my numbers are ticking up here. Just a reminder, today's session is being recorded and will be available to folks for later viewing. The way that we will handle the questions and answers, because I know that there are sure to be some, is we're asking you to put your question in the chat box so that we're able to collect them and respond to them at the end. We'll also have the ability to unmute folks as needs arises. So without further ado, let me just further introduce to you the folks that we have waiting. Obviously, our main presenters, Dr. Clay Mann, a friend to NASEMSO and all the EMS community in regards to EMS data. Clay has been very instrumental in helping many of us understand the use of data and better ways to access data. So from the NEMSIS TAC, he will be our main presenter. Also available to you is Eric Cheney from the NHTSA Office of EMS. Eric's also been a long-time partner with NASEMSO in helping us making sure the lines of communications are open and that folks get the information that they need. And last but not least, our Executive Director, Dia Gaynor from NASEMSO will be available to answer any state-related questions that you may have. And without further ado, Clay, I'm going to stop talking and turn the meeting over to you now. Thank you again very much for providing this presentation and for being open to our audience for questions.
Yeah, thank you, Kathy. It really is a pleasure to be with folks today. I'm sure there are many long-standing advocates of trauma care and EMS care on the call, and I look forward to when we all get together again face to face. But until then, thank you for joining, and thank you for Dia, Kathy, and Eric making this opportunity available to kind of talk about what is up and coming in regards to perhaps improved ability to link trauma registry data with EMS patient care reports. So kind of an exciting topic. I would love to have questions asked during this hour. I have a set of about 20 plus slides that we'll go through, but really I'd like to be able to address any kind of questions that states are having in regards to this potential linkage between these two registries. There's been some confusion about the UUID. I'm hoping that this presentation will educate you as to kind of how the idea came to be and how it will be materialized over the next couple of years to kind of help you and aid you with answering questions that are probably coming up for you within your state. This is a presentation that is geared towards focused on state representatives who deal with trauma data or with EMS data. And so hopefully I can address those questions, and please feel free to add any questions to the chat and we'll address them at the end. All right, so I'm going to go ahead and move forward and maybe talk a little bit about the history, why we're at this point, why we're discussing the use of a universally unique ID that's available in NEMSIS and transferring that over to trauma registry records. And we'll talk about that in greater detail, but why was the topic even kind of surfaced? In 2016, there was a study that was funded by DOD and DHS and NHTSA, looking at, it was a consensus-driven a group of experts that were brought together to look at, wow, we have these siloed trauma systems that exist in the military side of the United States, and there's also the civilian side of trauma systems. Both have been incredibly successful at reducing the fatality rate from severe injury. why are we not bringing these two siloed systems together so that each could take advantage of advancements that have been made in each of those two registries? And so that was the purpose of this 2016 study and consensus group. Lots of great experts were associated with this project, really rich with lots of expertise on both sides, on the military side as well as the civilian side. It was a great exchange of information. The idea was, wow, couldn't we develop a national trauma care system really that allowed the military side trauma system to be able to speak with the civilian side trauma system, join together not only the data but best practices and system design and even personnel between the two systems, really to improve both. It was a fantastic idea. There was a number of really good recommendations that came out of this 2016 meeting, and the document that I showed earlier was a document that prevailed from that meeting. There were a number of recommendations that were made by this group. One of the recommendations, recommendation 5, kind of focused on this idea of improving data collection and data use between these two siloed registry systems. And there were like 6 endorsed actions that came out of that recommendation 5. And one of those that's highlighted here in red, I'll go ahead and read it, was a recommendation or an endorsed action to have the American College of Surgeons, the National Highway Traffic Safety Administration, NHTSA, and NSEMSO work jointly to enable patient-level linkages across the NEMSIS National EMS Database and the ACS National Trauma Data Bank, the NTDB. So that was a recommendation that came out of this group. ACS, NSEMSO, and NHTSA took this to heart, and they put together an expert panel funded through NHTSA to look at, hey, how could we ensure that there was this kind of patient-level linkages between NEMSIS and the NTDB, so that probabilistic linkage, other things that are kind of happening now in these siloed registries at the state level could be overcome, right? And even at the national level, how incredible would it be if the NTDB and the NEMSIS National Database had some way of linking together the patients, right? That would be fantastic. Well, at the same time, when NHTSA brought together these experts, NEMSIS had been playing with this idea of including in NEMSIS a UUID. So a UUID is a universally unique identifier. That's what it stands for. It was originally created by Microsoft and was called a GUID, a globally unique ID. What the idea was here is for every implementation of software would have a random number generator built into that software that generated a number that was associated with that record or that file that was being developed inside of Microsoft. And then that UUID would just travel with that PowerPoint presentation or that Word document. And so that if there was ever, if that document was ever brought up in a shared environment, this UUID would be used to find the original copy and then update it, right? So it's this really cool idea. It's a very complex number, as you can see here with this example. It's so complex that it can be considered universally unique. So even though every implementation of Microsoft software has its own generator, the possibility that these two random number generators in two different your version of Microsoft in your house and a copy of Microsoft in my house, the idea that those two independent software implementations would ever generate the same GUID or UUID is almost an impossible a thing to happen, right? So 2 to the minus 22, much much less likely to occur that there'd ever be a GUID collision, that they call it. That is, these two independent generators would ever generate the same number. You're much more likely to win Powerball, right? And I'm still waiting for that to happen. So it's a unique idea, and NEMSIS thought that this would be incredibly valuable to implement, because on the EMS side, EMS will often generate a patient care report, but the patient was unconscious, or for some other reason they weren't able to completely fill in all the data on the report. Perhaps insurance information will come later. Well, you can see from this picture here that as EMS is completing these records and submitting it to the state registry, so client X or client Y or client Z, these random number generators are generating this UUID that could go up to the state server. And then if client Y, if EMS agency Y ever went back and updated a record, a patient care report, well, that UUID is still associated with that record. When that renewed record or fully fleshed out record goes to the state server, that UUID is used to find the old copy and now replace it with the new copy with the additional data. So that was the idea of adding a UUID to NEMSIS version 5 that is now beginning to kind of roll out. So we're under version 3.4, and 3.5 was developed so that there is this random number generator, this UUID mechanism that exists within NEMSIS version 3.5. And every time a patient care record is generated under 3.5, a UUID is generated, and now it flows between the EMS agency to the state, even up to the national level. So as records are updated, it can always find the previous record and update it. Well, so let's try to put these two ideas together, right? So this expert panel indicated, hey, can we record level link trauma data and EMS data? Well, this UUID could be used to do that, right? How would we implement the NEMSIS UUID on the trauma side? So this is a busy slide, and I apologize, but I'm gonna walk through almost every word of it just to make sure that we're kind of clear in our head about how this would work. So if the National Trauma Data Standard, the NTDS, which is what the National Trauma Data Bank is based on, so there's their standard of elements. If it included an element to document the NEMSIS UUID in the trauma registry record, then there could be a linkage that exists between the two, right? So a hospital registrar uses their established process for connecting together an EMS record and an inpatient record to complete a trauma registry record, right? So they're sitting in the hospital, they come in the morning, and they're going to complete some trauma registry records. They somehow have access to the EMS data. They somehow have access to the inpatient hospital record. They complete the trauma registry record. If that registrar could connect those two records together, the EMS patient care report and the inpatient report for that patient, make sure they're the same person, then this UUID could be electronically exchanged across the systems to ensure that the UUID now exists in the EMS record, in the original EMS record, but now it also exists in the new trauma registry record. So if that record now moved forward, it's transferred to the state, it's transferred to the national registries, there would be this unique identifier that existed in both the EMS record and the trauma record. So let's try to visualize that a little bit and maybe talk about it. So clearly the idea here is, as we was just describing, there's our trauma registrar coming in for the morning. Whatever he or she uses to identify a hospital record for a patient and whatever they use to identify an EMS record, they sit down to complete a trauma registry record. And they say, oh yeah, this is John Green in a vehicular crash yesterday morning on the corner of State and Main. he or she sees that information in the hospital record, sees that information in the EMS record. Yeah, this is the same patient. These are the two records associated with the same patient. They would associate those two sources of data. This is the same patient, and then once that was done, the software would automatically recognize that the UUID could be moved from the NEMSIS record to the trauma registry record. And so now this UUID automatically flows across. It has to happen automatically because, as you saw, it's a very complex alphanumeric code that could never be copied by a registrar. It just introduces too much potential for error. But if that moved across, then the real value is at the hospital level. They have a direct link if they ever needed to use it. The trauma registrar linked them, so there probably wouldn't be much of a use at the hospital level. But if now, when that EMS record travels to the state, and that trauma registry travels to the state, there's now that same UUID that exists in both of these siloed registry databases at the state level. So now they both have the same number for the same record that are connected. So the UUID could be used to link them together at the state level. So probabilistic linkage that's used now, it's complex. It's not always as correct as it could be. This link could be much more of a solid way of tying together those registries. Then imagine if states approved the movement of that UUID up to the national data sets, up to the NEMSIS national database and up to the NTDB and TQIP databases. Wow, it would be incredible, right? Because now there'd be a way for researchers and state officials to access national data that's de-identified, and we'll talk about that in more detail, that's de-identified but is already linked for them with a sure way for linkage. Okay, so that's the idea. And I don't see any questions yet, so I'm hoping that I'm explaining this well. If there's questions, feel free to ask them, and I'll try to address them. Well, so this process, the value of this process will really only be realized if states see the value of this and understand the confidentiality and kind of anonymity of this process. So let's talk about that. There's a document that's available to you as state representatives that's really built for you to kind of socialize this idea, and it's available on the NEMSIS website. If you go to the NEMSIS website and just click on using EMS data, there's an area called NEMSIS 101, so just kind of the beginnings of NEMSIS. You scroll down just a little bit under understanding NEMSIS 3.5, you'll see this document found right here. So the ACS and the SEMSO joint linkage policy documents. This is the very document I was talking about. Well, so what I want to do is perhaps just walk through some highlights of this document. It's only 10 pages, but let's walk through the description that it offers for this potential use case and talk about maybe some of the ideas that need to be kind of fully understood to make this work well. So first of all, and probably most importantly, is that this UUID that could travel from a hospital to the state to national registries is completely void of any information that speaks to a patient, to a provider, to an EMS agency, or to a hospital. It has no intrinsic relationship to any of those things. It is merely a random number generated to identify a record. So the UUID remains meaningless unless you have both, if you have access to both registries, right? It doesn't include a snippet of social security number or of a date or of the name of a hospital. There's nothing like that in there. And so because of that, it really is is a unique way to exchange data just like Microsoft does without running the risk of like sharing PHI or PII. If the NMSIS National Registry is de-identified and the NTDB is de-identified, has no PHI or PII, the addition of the UUID will not add any more discernibility or discoverability associated with the identity of a provider or a hospital or a patient, because it's just a number that identifies two de-identified records that come together. So it could be incredibly valuable in that way. The reason why value is added is because now we have this same unique link between EMS and hospital records for trauma patients who utilize EMS across the entire country at the agency level, at the hospital level, at the state level, and even at the national level. And as I mentioned, it's much more efficient, much more accurate, much more precise and reliable than probabilistic linkage used to try to bring together two quasi de-identified data sets and trying to identify patients and so that they could be linked together. That's basically what probabilistic linkage does. This removes all of that complexity by just having this, what we'll call a deterministic link, an actual link between the two registries. And it's a consistent process used across the nation and across time, right? So you don't have these different probabilistic linkage models used in Connecticut compared to Utah or Washington, or even differences over time. So,
hey Clay, Kathy Robinson here. Sorry, I don't mean to interrupt you, but we're getting several similar questions, and this seems to be a better time to ask it. Is if you have a layered response and there are multiple EMS agencies that are responding to the same incident that might generate a patient record, how will you deal with that within the model?
Yeah, great question. Thank you. And that technical guide that I was just going to talk about, and we'll talk about that a little bit. The technical guide hasn't gone out yet. We'll talk about that in a moment, but it covers this topic. The idea is with the use of this UUID to begin with, that it would only allow the EMS transport into the hospital being recorded into the registry. So it would just be the UUID that was associated from the patient. Let me restate that. It would only include the field level patient care report coming to the initial hospital. So you're right, that is complex. The NTDS has an ability to include not only information from the field patient care report, from the first patient care report, but some limited information from an interfacility transfer, right? So if they're taken to a level 3 trauma center and then transported to a level 1, the UUID would only cover that initial connection between the field to the first hospital. Now, a level 1 or level 2 could implement data or the UUID from the interfacility transport, but I don't think the NTDB is supporting that right now. I think they're only supporting the initial field record. All right, then I also see there's a question about once the hospital record and the EMS record are manually linked, does the registrar have to pull over that UUID? No, and that's some of the confusion. It should automatically come across. And let's talk about that technical guide that we're right now rolling out to software vendors, both on the EMS side and on the trauma registry side. There's a work group that's developing this white paper. It's under review right now with this work group that includes software from both sides of this exchange. It really talks about, and we can make this available to states as well, how this would happen, right? How the data would be moved across. And you can think about this, I don't know, in the next couple of years or within your hospitals now, there's some way for that trauma registrar to see an EMS record and a hospital record. This system will only work once an electronic exchange of data can be made, right? So if in a hospital they're still looking up an electronic PDF in an HIE or in some type of a hospital register or some type of a state registry for the EMS record, and it's just a PDF, this will not work, right? It needs to be an electronic copy of the EMS record and electronic copy of the hospital record to make, or the trauma registry record to make this automatically flow. And we can talk about that more in just a minute as well. So that this white paper talks about how EMS data using the NEMSA standard can be made available and expose a UUID to an electronic trauma registry record so that it can pick that up and bring it across once the registrar has identified two records that belong together. So, and there are some complexities associated with that, and this document kind of talks about that. So happy to make that available once it's released. So let's talk a little bit more about that state document, what's in there that you can share with your state. It also talks about value added due to data quality, right? We talked about this. The cool thing about this is probabilistic linkage, you always just had a, quote, probability that two records actually belong to the same patient, right? And that probability can be good or that probability can be bad based on the quality of the underlying elements for linkage. With this process using the NEMSIS UUID, the linkage between the two records happens by the registrar who sees the name, who sees the event, who sees the location of the injury or the location of the event, right? And can read narratives in both the nurse's notes and in the narrative in the EMS and say, hey, yeah, okay, this is John Green and this vehicular crash yesterday afternoon, right? And I can be sure that these are the same records. And so the quality of linkage goes up because it's done by our very qualified trauma registrars who do it every day right now and are trained to do it. And then that UUID, by exchanging it manually, there's no human intercession, there's no trying to copy it or copy and paste it. It would move across automatically. So the quality of matches and the quality of the linkage is both improved with this approach. Cost to the state. So clearly the opportunity to kind of take advantage of this UUID that is going to exist in the EMS PCR, and there is a placeholder in the NTDB, in the National Trauma Data Standard. Really, the cost of making this happen will be small. It has to be integrated into the software for NEMSIS 3.5 and for future versions of trauma registry software. But once that's done, then I think the additional costs that have been associated with supporting personnel and software and materials for probabilistic linkage and for other things and maintaining that expertise, that could be reduced at the state level with use of the UUID. So politically, right, we have states have to be okay with this. I mean, states have to understand that this is another element that we're trying to share into the state registries and into the national registries. They need to understand that it's completely free of PHI and PII. It needs to always be an opt-out, right? It always needs to be an optional process for states, and so that states approve its use. It's not mandated by the American College of Surgeons or by NEMSIS. And there'll be early adopters, there'll be those that wait behind, and that's how we see this kind of rolling out once the technology is available. So the state utility, well, just think about that at the state level for your for what you attempt to do to improve the care in the pre-hospital setting and in the trauma when an injury occurs, right? I mean, having this direct link could allow other systems to utilize this that have a registrar type person bringing data together. CARES tries to bring together hospital and EMS data. AHA registries do the same thing. CODES does the same things. FARS do the same thing. There's lots of state registries who, if there's a human trying to bring together two records to make that linkage, that UUID could electronically pass across and bring real value. For the EMS side, the true value of this is to have the ability to look at EMS care in regards to trauma outcomes. Wow, how cool would it be if in the near future, with this type of linkage, allowing close to, not real time, but probably like month-old data instead of 2-year-old data that often exists within state registries that need to be probabilistically linked once the data is available within 2 years. It becomes very hard to improve EMS performance to think, wow, what happened 2 years ago? Well, having this more real-time system where perhaps a trauma registry record is completed within 3 weeks or a month, I mean, it could be truly valuable for EMS. So let's talk about this current state, right? We're about halfway through our time. That's the background, that's the history, that's what brings us to this moment. There have been advances made on both the ACS side and the NEMSIS side that have kind of complicated the vision a little bit of kind of understanding how this might work. So let's talk about where we are and how you as a state kind of educate your hospitals and your these fine trauma registry folks that work so hard and are so detailed. They're so detail specific in what they do. They want to make sure that they understand how this will be used. So let's talk about where we are, and I'd love to open it up for questions to see if there's a way for us to clarify this more for you. The American College of Surgeons did remove the EMS elements from the National Trauma Data Standard for 2021. I think most folks have noticed that. They've included the NEMSIS UUID in the NTDS for 2021 as kind of an element among many that you would see if you opened up their data dictionary. And the idea was here, of course, right? States wouldn't need to collect these 32 EMS elements off of the trauma registry record. If the UUID came across, then the state or the nation would have all of the data associated with the patient care report available by just linking two data sets together using the UUID. So I think the ACS here was just thinking, wow, there's a way to really lessen the burden of data collection on our trauma registrars by not requiring the hand entry or the cutting and pasting of those 32 elements. So those were removed. At the same time, the rollout of NEMSIS 3.5, which includes the UUID, was greatly delayed by the pandemic, and we really don't see any version 3.5 of NEMSIS implemented anywhere in the US yet. Software companies are just now coming to us for compliance testing for 3.5. Some have passed 3.5 compliance, but I don't know anywhere in the country where there's EMS agencies and a state on the 3.5 platform yet. So really, a national implementation of the use of the UUID for this purpose that we've been talking about is probably not going to happen until 2023 or 2024. So the interest and kind of comments that have come up related to UUID are a little early to talk about, and they're also, it's kind of an under the hood thing, right? If you think about what we've just talked about, it's really about trauma registrars just doing the same job they're doing now with electronic copies of the EMS PCR and the trauma registry software just doing what they do now, and under the hood, this UUID travels across into the trauma registry. So ACS, recognizing that there was some confusion that was happening in regards to this, has modified their 2021 data dictionary, and they've added the phrases that I have here outlined in red, right? So they make the point right up here high, right after an example of a UUID, they indicate, hey, this is an automated extraction between these two. This should be an automated process of that UUID passing over into the trauma registry record. And before that automated technology is available, it should just be reported as not known or not recorded, right? And that's going to happen probably for most of 2021 and probably into 2022 before EMS agencies and states move to a NEMSIS 3.5. If you can't document it, right, you need to document it as a not known, not recorded, and there will be, they mentioned there's a way here that hospitals and states will be informed that version 3.5 is active in their state. We can do that, but again, I think the vision of this is for the trauma registry folks not to even have to worry about this. They'll just see new software that allows them to just link their records together and then just have under the hood the record flow across. So, and then also in answer to the question that was raised in the chat, that last red square, which of multiple transports by EMS could be included in the hospital record? And this is a little bit misleading because it talks about maybe an interfacility transport to a level 1 or level 2 could be put in because that's the EMS agency delivering the patient to your hospital. But you can see 2 bullets above there that if it's an interfacility transfer, it would be listed as not applicable. So even in this description, we need to clean this up. And I realize that there's still some issues even within the NTDS data dictionary that we need to clean up a little bit. But bottom line, we're working with the NTDB right now. States have brought to the attention the idea that their trauma registry data collection is mandated in law, and it follows very closely the NTDS. And so we're working with the ACS to maybe think about the idea of maybe having the EMS and elements that states are traditionally used to collecting, maybe those could just set as optional elements within the 2022 NTDS XML, right? So states could continue to collect it and report it to fulfill regulations. We're working with them to see if that can work. And then NEMSIS, of course, we're very busy building exchange tools for NEMSIS, right? So whether that trauma registrar sitting in a hospital, if they call into a community-wide or statewide HIE for EMS data to connect to the hospital record to link those 2 records, we're going to ensure that there's like HL7 FHIR tools. FHIR stands for Fast Healthcare Interoperability Resources. That's the current standard for the exchange of data. We're making sure that EMS data can move smoothly between HIEs, health information exchanges, as they might exist within your states. So that's work that's happening right now to kind of improve the messaging associated with the use of UUID. And I would love, through the chat or through open dialogue, how can we better improve the understanding of this potential use of the NEMSIS UUID, and how can we take the focus off of the UUID itself? It really is kind of an under the hood thing, right? I mean, we use PowerPoint every day, we use Microsoft Word every day, and GUIDs are in active use every day, but we never see it or talk about it, right? Just because it's kind of under the hood, making sure that updates to records exist correctly. So it should be the same here, right? It's just something that moves across under the hood, and our registrars don't need to worry about whether it's there. If it's done correctly, it should all happen under the hood. So I'm gonna stop there with the idea that we have some time left for questions, and I would love to see if there is some way to discuss what we at NEMSIS or the ACS could do to better communicate and improve the understanding of the use of the UUID.
Hey Clay, we have actually several comments in the questions box. I think Dia's been trying to hand them off to you, but obviously a common theme is about multiple EMS agencies being involved in the care of a patient, and making sure that nobody's contribution to that effort is not excluded. So I don't know if you have any thoughts about that generally. Folks that are interested in speaking to Clay directly can raise your hand, and we're monitoring that for folks that want to do that. But I guess
Yeah,
reflecting on the multiple hands that touch a trauma patient, and wanting to make sure that that is properly documented.
Yeah, great question. And let me speak to that directly now that we've kind of got through the presentation. I'm going to go back to that technical guide that you can see here. Right now, the UUID that has the placeholder that's been put in the National Trauma Data Standard is a 1-to-1, meaning it can only accept one UUID into that trauma registry record. The idea that we're talking about here is well taken, and there really isn't any reason why that placeholder in the NTDS couldn't be a one-to-many, right? So that for one patient, many UUIDs could be reported and made available in the state registries and the national registries by just allowing more than one to be able to come in. So that's in the works, right? I would imagine in the next version of the NTDS, it'll become a one-to-many, so that multiple patient care reports can be included in the record. As it stands right now, the ACS has envisioned this as just the field level ePCR goes into the initial patient care trauma registry record of the initial receiving hospital. That I think will be expanded even with just the 2022 data dictionary, and so I think even before we implement it, there'll be a way to include multiple PCR UUIDs into a trauma registry record.
Thanks for that. Just scanning the other questions. Once a patient PCR is identified by the registrar and linked to the state registry, does the data automatically transfer from the PCR to the state registry, or is it still manually inputted by the registrar?
Great question again. That is part of what this technical group is talking about, and it's actually the former. The idea is that once these the trauma registrar has access to electronic copies of both the PCR and the a trauma registry record, and the UUID can flow across. Why not have all the data that a hospital wants or a state wants from the EMS record, have that flow over as well? And so that will happen. It seems kind of intuitive that just takes away the value of the UUID, but it really doesn't, right? Because a hospital or a state may want the name of the patient or the address of the patient to flow across from the ePCR into the trauma registry record. But then at the state, they don't want to share that with researchers, or the data that comes up to the to TQIP or to the NTDB or to the EMS national database. Those are always limited data sets. That is, all PHI and PII has been removed. So there again, the UUID becomes this master de-identified link to bring together state and national registries. So yeah, you're right. Once the ability to electronically exchange a UUID between a trauma registry record and an ePCR from an EMS agency, yeah, let's move over the data too. so that the trauma registrars don't need to move it over manually, and it's available at the hospital, right? Why not have that all move over? So that's part of that technical group that's meeting. They'll make sure that that happens.
Well, I'm thinking that this is just, the first of many conversations that we're going to have on this particular topic. A great interaction from the group today. Another question: if false identifications of patients by registrars happen, could the UUID link be undone and reassigned?
Yeah, great questions. This technical group is also working through the process to ensure that that can happen, right? So they can back out a decision that 2 records were the same. So that's part of that technical guide. There'll be a national standard for how to remove that link and reestablish it.
I am going to, we have a hand raised in the audience. Brian Simonson, I'm just giving you a heads up there because I'm going to unmute your microphone and offer you the floor. And there you go. Brian?
Can you hear me okay?
We sure can. Go ahead.
Hey, this is Brian Simonson. I'm in Wilmington, North Carolina. I'm the Southeastern North Carolina trauma coordinator. A couple questions. You answered one of the ones that I put in the discussion as far as the transfer of data being automatic or if the registrars are still doing it. The other question I have is, just so I have it straight in my head, current state, we're talking about a national identification number is basically what this is. Current state, the pre-hospital PCRs automatically generate a unique number to that PCR. And then when they're in the hospital, they get a medical record number. It's the job of the registrar to identify the PCR and the medical record that they're going to be working with as being the same patient. And then when they start putting it in our registry, they get a trauma number assigned to them. That is the overall assigning number for that patient and that event. How is this number different? I don't understand how this is different. Is this just open it nationally, or is that the intent of it? And if it does open it up nationally, and now we have this national, how do us local researchers and trauma geeks access that data in a easy manner when we do our research? What's the process behind that? And part 2 of the question is, on your slides, it says the ACS has removed the EMS elements from NTDS for 2021, and it doesn't seem like full functionality of this is going to happen until 2023, 2024. Are we just going to be devoid of that pre-hospital, that very valuable pre-hospital data in the interim?
Yeah, great questions. Thank you. I'll begin with your first question. Yeah, so there's, you're right. There's going to be unique, I'm going to put that in quotes. There's going to be unique numbers that are associated with the EMS record and the hospital record and the trauma registry record, but there's no mechanism right now to ensure that that number is unique across the nation, right? So right now in NEMSIS, we have agency IDs, and so states assign ID numbers to all the EMS agencies in their state, but I could have that same number 001 in North Carolina and have that same number for an agency in Utah, my home state. So those IDs probably work well to do linkages at the state level if there was a mechanism to move the unique IDs between the EMS record and the trauma registry record. Some states and some registrars have thought that's what they were supposed to do with this new placement of the UUID in the NTDS, but that's not what it is. That's not a UUID. Those IDs probably work very good at the state level, but there's no guarantee that those are unique across the country, right? So that's the value of the UUID. Just like you mentioned, it brings that uniqueness to the national level. Then I think the next question was related to the fact that the NTDS has removed those EMS elements. That that is a problem. And the idea that it will be removed from the National Trauma Data Bank or from TQIP is something that they're wrestling with right now. That's kind of why those last couple of slides I talked about the fact that this work group, this UUID work group, is actively involved with the ACS to determine how best to walk back this decision a little bit and to protect state law, to protect the collection of EMS data, and then to somehow allow researchers to still look at the care and exchange of care between EMS and trauma. So I think the one question I miss is how would you as investigators or the geeks like you and me that want to be able to look at trauma care and EMS performance, right, and how that works. When this system is in place, what could happen is that a researcher, as you can see here at the very far right of this whole slide, is those researchers, state officials could contact a TQIP or contact the National EMS database and say, hey, we want you guys to hook together all the patient care reports where they brought a trauma patient to one of our hospitals in the state of North Carolina. And then we could provide those UUIDs associated with the NEMSIS data and have TQIP pull those records, or have the NTDS or the NTDB pull those records using those same UUIDs and provide you as a researcher in North Carolina with the ability to bring together the trauma registry and the EMS data for that same patient. That's the vision for researchers and state officials and super geeks.
Can I add one last question to that?
Oh, yeah.
Okay, yeah. So, and the other thing that comes to mind, well, first of all, it still blows me away with the ACS. Trauma is a continuum of care, and you got to start at the beginning of the problem and go all the way through the end of the problem and look at all those values before you can make any kind of reasonable decision on how to improve care. That's just my humble opinion. But when we start talking about a transfer of data from the pre-hospital side of the house to the registry, what are we doing about mapping issues? I mean, there's multiple different electronic generated PCRs in the industry, and I still have some organizations that actually still do handwritten charts and then scan them into the system. You know, somebody might call an arm broken, somebody might call it fractured. How do we ensure the quality of the data that's being transferred across just by using this unique number, and ensure that we're comparing apples to apples and not apples to oranges?
Yeah, it's a great question. That this work group, I'm just going to show you a piece of this document, right? So this is the white paper that's under review right now that we talked about during the presentation. That very idea is being brought up here, right? If this is going to work, then we as an industry on both the trauma registry side and on the EMS registry side need to talk about how a standardized way that trauma registrars are going to be able to search through EMS records to find the link, right? So I think in answer to your question, I think the introduction of this UUID and now the idea of a trauma registrar being able to do the linkage is going to bring forth a whole new kind of standardized way for the electronic searching of EMS records. So I think in the next couple of years, with all the software companies working together on the EMS side and the trauma side, I think you'll see better searching opportunities made available to our trauma registrars.
Clay, there is a question about kind of futuristic, whether this model, while we're talking about trauma patients now, would this model work for other sorts of time-sensitive conditions? And do you see that happening in hospital registries and STEMI patients or stroke patients or those sorts of things?
Yeah, we're in active negotiations and discussions with the American Heart Association. Actually, we have a call with them this week with the CDC and their stroke registries, head trauma registries. Yeah, there's lots of discussions going on about how this UUID could just ease the burden data collections and the efficiency of adding EMS data to Coverdale, to get with the guidelines, to codes, to FARs, lots of different data sets. I think the same model will apply.
And obviously, a lot of states still figuring out pieces and to the process, but there is a question about how will EMS and trauma systems be linked for no cost?
Yeah, yeah. So for no cost, I tread a little carefully here, but the only cost that I can see would be to update the software, right? So this process doesn't rely on probabilistic linkage or, you know, someone who can do that really well, a statistician trained to do that kind of thing. It would be an added feature to the trauma registry software and to the EMS software. Will there be a charge associated with this? I don't know how they could charge for this one feature. The UUID in NEMSIS is mandatory, right? So we're mandating that every NEMSIS compliant EMS software has to implement a UUID. So we'll make sure it's there, and the ACS will make sure there's a placeholder for it. I'm hoping that there's no special cost associated with the exchange of that UUID, but maybe in the search engine or some other process there may be cost. But I think if the state weighs this against the cost of doing probabilistic linkage, which is FTE and software and other things, I'm hoping this is more efficient for both hospitals and for states.
I'm not seeing any more hands raised. I mean, I don't think that I have walked through each and every one of the questions specifically. I mean, I think a lot of folks are trying to figure out how to operationalize this. I'm going to take a pause from looking at the questions. And Eric Cheney, I don't mean to like put you on the spot, but I certainly want to express my appreciation to the Department of Transportation and NHTSA in particular in helping us get the resources that we need to make this a reality. But I wanted to provide you the opportunity to make any comments relative to the discussion if you'd like to do that.
Hey, thank you, Kathy, and thanks to all who participated in the call. It's greatly appreciated. So I think thanking DOT and me in particular in this one is a little out of scope in that, you know, DIA had contacted me and said, hey, this UUID thing was worked on by ACS and the SEMSO. It kind of got finished, but it didn't really get completed. So we kind of dusted it off, and DIA kept pointing out the utility of it and how it could be used throughout the state level and how it could be a benefit to the federal and local level as well. So I'm happy to kind of get it out there. And what I would like out of this is anybody has questions, if you get the questions to Kathy and Kathy gets them over to us, we'll get them answered, and we'll get the answers posted so that in between DIA and Clay, whether they're posted at the TAC, whether they're posted at the SEMSO or both, that doesn't matter to me. We'll get those answers posted so that everybody can see them. And I think once this technical guide gets in your hands, it'll probably address a lot of the questions that you have. But remember, this is still in terms of process, you know, Clay pointed out 2022, 2023, and then it might not be fully implemented. So we're still learning what the capabilities are. We talked a lot about trauma. There's been talk about using this for cardiac as well. And there's been talk about using it at DOT, linking FARS data and MUC data, Model Uniform Crash Criteria and fatality database held by DOT. So I think we're just scratching the surface with what to do with this. And I look forward to input from anyone. And I truly mean that, anyone on the call, in ways we can make the process better, more clear, or add to its utility. Always open to that. Thanks, Kathy.
Thank you, Eric. I just put my email address in the chat box. If folks have a question that they feel hasn't been answered today, please feel free to reach out to me, and I can make sure that you're connected with Clay, with Eric, with other folks that might have some better answers than I might have to your question. Again, I think this is going to be the first in many discussions that we have about UUID and implementation. We really look forward to those discussions. Appreciate the transparency and being able to provide a preview of what we're going to be looking at going down the road. And I think because we're at the top of the hour and I don't see any more hands raised, I think that we hit most of the questions in the box, or at least paired some of them together. I just want to take this moment to thank Clay and Eric, Dia, and all of you for participating in this very, very important discussion. We will be posting a link to the recording, and again, so much appreciation to all that you're doing to serve EMS. That will conclude. Clay, I'm going to give you one more second if you gathered any thoughts and had a parting comment. Or we'll just end the discussion.
Yeah, no, Kathy, thank you. Yeah, just thank you for folks participating. Thank you for the questions.
All right. Thank you all very much. This ends the presentation of linking ePCRs and registry data. Have a great day.